thank you very much for the kind invitation, and it's my pleasure to give you an update on autoimmune chronic cholestatic liver diseases. I think we've really made some exciting progress over the last 20 years, and let me review some of this. I do not seem to be able to advance my slides. Okay, maybe there's some delay. These are my disclosures. So when we look at immune-mediated liver diseases, on one hand, we have the autoimmune cholangiopathies, primary biliary cholangitis, and primary sclerosing cholangitis. We also have IgG4-related disease, and of course, we have autoimmune hepatitis, and also the recent challenges with drug-induced autoimmune liver injury, including biological and checkpoint inhibitor-induced liver injury. When we look at the clinical spectrum, it's interesting to see that these diseases can actually overlap. So we have overlap with autoimmune hepatitis and PBC and PSC can overlap with IgG4-related disease. And also important to keep in mind nowadays is that there's an overlap with non-alcoholic fatty liver disease across all the different etiologies. Interestingly enough, however, patients with PSC, in contrast to patients with IBD without PSC, seem to be protected. So this is not yet entirely understood. Maybe this is related to specific changes in microbiota. So for the interest of time, I will focus on immune-mediated cholangiopathies. With primary biliary cholangitis, we have an effective first-line therapy, ursodeoxycholic acid, which prolongs life. And we have an effective second-line therapy for non-responders with FXR and PIPA ligands. In primary sclerosing cholangitis, however, there is no established medical therapy. The use of urso is controversial. We have the association with IBD and the very high malignancy risk, mainly cholangiocellular carcinoma, which contributes to nearly half of causes of death. When we look at the transplant indications in Europe, however, it's surprising to see that despite being rare diseases, immune-mediated cholangiopathies, mainly PSC on number 3, but also PBC on number 4, followed by autoimmune hepatitis here in comparison with current listing numbers for hepatitis C, are pretty prevalent indications contributing to the burden of liver transplantation. This on the one hand reflects that these are good indications, but on the other hand is also a reflection of our limited therapeutic options. When we look at the development of transplant numbers, actually here are numbers from the UK, we have a reduction in the numbers for PBC shown here in blue, while the indication for PSC is rising, shown here in red. A pretty similar pattern actually in the UNOS US database, with a rise in PSC, which kind of has stabilized off, and a reduction for primary biliary cholangitis. Perhaps this is reflecting the use of urso for PBC, which I mentioned is effective. With PBC, actually, we have a response-guided therapeutic regimen. So we start patients on urso. We monitor biochemical response, usually after 1 year, with typically looking at the reduction of ALK-Phos and AST below 1.5-fold upper limit of normal. When patients respond biochemically, they are doing fine. We continue them on urso. However, we have the problem of non-responders of 1/3 to half of patients which require second-line therapy. And here we have now several therapeutic options with FXR ligands, with obeticholic acid as approved therapy, with the PIPA ligands such as fibrates, and with the glucocorticoid receptor ligands such as budesonide, used mainly in the context of overlap with autoimmune hepatitis. So for this diagnosis of overlap syndrome, we actually need liver biopsy. The biochemical response is monitored either by different binary definitions, which I'm going to show in a minute, or scores such as the UK PBC and the PBC Globe score. So among the binary definitions of response to urso-therapy, we have the different criteria, with the city criterion, the most prominent being the Paris 2 criteria, which I've just mentioned, with the cutoff of 1.5-fold upper limit of normal. for ALP and AST and the normal bilirubin. We also have the continuous scoring syndromes such as the GLOBE and the UK PBC risk score, which have the benefit of having apps. So you can easily access them. Also our patients access them. So you enter the routine parameters and you get the calculated risk for 5, 10 or 15 years for death or liver transplantation. And the GLOBE PBC score works pretty similar. So it's an app which you can access with your iPhone or via the internet website. More recently, it has become clear that the target actually should be a normal bilirubin or a bilirubin below 0.6 fold upper limit of normal within the normal range. So patients who reach this cutoff are doing much better than those who still have a bilirubin above 0.6 fold upper limit of normal within the normal range. And of course, those do much better than patients with an increased bilirubin. And the same applies to ALK-Phos. So we have to revise our criteria that actually we aim at a complete biochemical response with the normalization of alkaline phosphatase and a bilirubin below 0.6 fold upper limit of normal. And this also raises the bar when we judge a second-line therapy. So when you look what can we achieve by adding on obeticholic acid, actually only 10 to 11% of patients normalize ALK-Phos, which is partly due to the fact that FXR is driving the transcription of alkaline phosphatase. So it's a little bit an uphill battle. We also have the problems of pruritus and the lipid changes, which is more the issue with NASH. With fibrates, we reach a normalization of ALK-Phos in 70% of cases, and with a positive impact on pruritus. Actually, due to the recent FITCH trial, actually pruritus may even be an indication for treatment with bezafibrate by itself. So clearly, this is the first choice in patients with itch and which have a cardiovascular risk profile. Budesonide, also here, 35% of patients normalize the alkaline phosphatase, although, as I mentioned, this is mainly the treatment used for overlap with autoimmune hepatitis. What about improving the response even further? So we also can combine fibrates and obeticholic acids, and this has been shown by 2 recent trials. I'm showing you one here, where addition and actually combination as a triple therapy is increasing the response rate from 10 to nearly 50%. So this is, for example, the case when fibrates follow the treatment of obeticholic acid in non-responder, you can increase this percentage. And it also works the other way around. There are also fibrate non-responders which may benefit from addition of obeticholic acid. What about the long-term benefit of these treatments? We know that with obeticholic acid and bezafibrate, actually both the GLOBE and the UK PBC risk score is improving with both drugs. We also have some data on liver histology with some degree of improvement or at least stabilization of fibrosis and ductal injury. And we also have the experience from the open label extension trial with obeticholic acid up to 5 years, and the encouraging real world data, which actually confirm the efficacy and applicability of this treatment. What about fibrates? Actually, here recently a large retrospective Japanese cohort has been published, which actually shows that patients on urso and bezafibrate have a better survival than those only on urso, but this also includes the urso non-responders, of course. This is retrospective data, no prospective data yet. We have ongoing phase 4 data for obeticholic acid collecting these hard point endpoints. When we look at the current therapeutic options, actually, and look at FXR ligands, we have obeticholic acid, but also more recently non-steroidal FXR ligands. We have the different PIPA ligands, not only alpha, but also alpha delta and pure delta ligands such as seladelpar and elafibranor, and of course with the glucocorticoid receptor ligands. So all of these three main therapeutic options are actually nuclear receptor targeted therapies, which work as immunometabolic drugs. I think this is very important to emphasize because so far biologicals and immunomodulatory treatments have been quite disappointing in terms of efficacy and or safety, for example, with negative trials for ustekinumab and for rituximab. So by targeting these nuclear receptors, we are able to achieve an impact on both biliary homeostasis and inflammation and immunity. And it's interesting to see that I've mentioned we also have non-steroidal FXR ligands, which no longer have the bile acid structure, such as cilofexor and tropifexor, and they have FGF19 mimetics. FGF19 is the downstream target of FXR produced in the gut, but they're also mimetics of this gut hormone, such as aldafermin. We have new PPAR ligands, such as the mentioned alpha and delta ligands, and the combinations treatments of fibrates and FXR treatment. And also in the avenue of antioxidative and immunomodulatory therapy, we have exciting new development with NOX inhibitors, such as setanaxib, and novel immunoinflammatory approaches, for example, targeting the JAKs or the IL-17 pathway, or very interesting, the S1P receptor antagonists such as the etrasimod, which are also used in the field of IBD and multiple sclerosis. So we'll see whether these novel immunomodulatory approaches may be effective and more effectively work than approaches tested so far. One thing to keep in mind is the recurrence after liver transplantation. Despite immunosuppression, which already shows you how difficult it is to control these diseases immunologically, the highest recurrence rate is for overlap syndrome, but still for PBC, PSC, and autoimmune hepatitis, we have recurrence rates in the range of about 20 to 30% when those patients are followed up for 10 years. And this can be prevented by ursodeoxycholic acid. This is a recent trial published in JHAP that with preventive urso, the rate of recurrence is dramatically diminished. We do not know at the moment what those novel second-line treatments are doing for recurrence. There are no trials ongoing at the moment, but future hopefully will tell us. So what about primary sclerosing cholangitis? So in contrast to PBC with effective first and second line treatment, there's no established medical treatment with urso. Urso is actually controversial in the treatment of PSC with the issue of inflammatory bowel disease, with this typical right-sided dominance and the increased risk of malignancy, both in the colorectum and especially in the hepatobiliary tract, with the risk of cholangiocellular carcinoma in PSC. What about the current therapeutic options? We have the bile acid-based and nuclear receptor-based therapies. In addition to urso, there's an interesting development with ursodeoxycholic acid and urso derivative, which I will tell you more about in a minute. We also have data with FXR ligands and fibrates in PSC, which are encouraging and show improvement of alkaline phosphatase. Microbiota, very interesting topic. Of course, there's dysbiosis in PSC, which is different from IBD without PSC. And there are encouraging data with vancomycin, which may work by modifying gut microbiota. Vancomycin also has immunomodulatory actions, and the data are not yet sufficient to recommend it in clinical routine. There are interesting trials which have been completed with fecal transplantation or bacteriophage therapy ongoing tested strategy to modify gut microbiota. Overall, very promising. Immunomodulatory therapy has really been disappointing. So similar to PBC, classic immunosuppressives and also biologicals more targeting the associated IBD, such as anti-TNF strategies or vedolizumab, have been disappointing and failed to show improvement in alkaline phosphatase. Perhaps we have to diagnose the disease earlier and treat before sclerosis. Also, antifibrotic strategies with simtuzumab have not shown efficacy in PSC as in other indications. The interesting development is that we may have to revisit the use of endoscopy. Currently, we use endoscopy for workup of dominant strictures to exclude or diagnose malignancies or to relieve symptoms such as cholangitis and pruritus. And there's interesting data from centers that actually scheduled endoscopy, irrespective of symptoms, on a routine basis may prolong survival in patients with PSC. Of course, there's a risk benefit balance, and this is a strategy which is followed in few very experienced centers, and I think it's not yet prime time to roll that out broadly. But it's interesting because, of course, we combine ursodeoxycholic acid with endoscopic treatment in our daily clinical practice. So I've mentioned this new development, which is no-ursodeoxycholic acid, which is a derivative undergoing a so-called cholestatic shunting within the liver. So no-ursodeoxycholic acid, which recently has been renamed as neurocholic acid, is lacking a methyl group from ursodeoxycholic acid. And nor-urso, in contrast to ursodeoxycholic acid, is no longer able to undergo conjugation with glycine and taurine. And this resistance to side chain conjugation results in a so-called cholestatic shunting with a generation of bicarbonate-rich cholerasis, which is protecting the bile ducts. Interestingly and importantly, nor-urso is not a ligand for classic bile acid receptors such as FXR and TGR5 receptors, so it's an add-on strategy which has interesting potential. So due to this cholestatic shunting, nor-urso is generating a bicarbonate-rich bile flow, which protects bile ducts. And actually, we know from animal experimental data in mouse models of sclerosing cholangitis that it also has direct anti-inflammatory and anti-fibrotic activity. And through this cholestatic shunting within the liver, nor-urso is reaching very high levels at the level of the injured bile duct. More recently, we could demonstrate that nor-urso also has immunomodulatory effects, which are partly mediated by inhibition of mTOR. So it's also an immunometabolic drug impacting on T cell metabolism of CD4/8 and of T cells, and modifying the proliferation and the immune response of T cells in the liver and in the gut. Recently, a phase 2 study has been completed, which showed a dose-dependent reduction in alkaline phosphatase and other liver enzymes. This effect occurred independent of previous exposure and the efficacy of nor-urso, and importantly, pruritus was not a side effect. So based on these very encouraging data, a phase 3 trial is currently ongoing with several centers also in Spain. So we are hopefully to be able to finish recruitment by the end of this year and have data on the impact on histological and clinical endpoints in addition to biochemical endpoints soon. In addition to nor-urso, also a non-steroidal FXR agonist, cilofexor, has been tested in phase 2 trials, which also showed improvement of alkaline phosphatase in response to placebo. And also here, interestingly, in contrast to obeticholic acid, which is the steroidal FXR agonist, no pruritus was observed as a side effect. And currently, cilofexor is also evaluated in a phase 3 trial. Actually, recruitment already has been completed for this trial. So hopefully we will have data of 2 phase 3 trials for nor-urso and cilofexor in the near future. In addition, we also have FGF19 mimetics. FGF19 is the downstream signal of FXR. And these mimetics actually have metabolic effects without the tumorigenic effects. The problem is that induction of endogenous FGF19 may promote proliferation of cells. This is, of course, an issue in a disease such as PSC, where malignancy is a major concern, but FGF19 mimetics do not have a tumorigenic effect. And there are actually encouraging data both in PBC and in PSC. In PBC with the reduction of alkaline phosphatase and bile acid synthesis reflected here by C4 levels. In PSC, interestingly, there was no impact on the primary endpoint alkaline phosphatase as in PBC, but a significant improvement of non-invasive fibrosis parameters such as ELF score and PRO-C3. So maybe there's a direct antifibrotic effect of FGF19 mimetics, which of course is of benefit in a fibro-obliterative disease such as PSC. A very interesting development are biliary organoids. Biliary organoids are mini organoids which can be derived not only from biopsies and inducible pluripotent stem cells, but also directly from bile. So by collecting bile, you can grow these organoids as shown here. And these organoids actually have the typical inflammatory response, for example, to interleukin 17 with induction of pro-inflammatory cytokines. You also can co-cultivate these organoids with immune cells, and you even can derive intestinal organoids from the same patient. So this could be a way towards personalized medicine in PSC, perhaps stress testing drugs or combinations for drugs, at least in development, and perhaps also in the future on an individual basis. These organoids are also an interesting avenue for regenerative medicine. You can inject these organoids into the biliary system and perhaps may help to heal the bile ducts. So we know from these cholangioscopic images that those bile ducts are really severely inflamed. It really looks like an inflammatory bowel disease of the bile duct. So in summary, I hope I could show you the recent developments of over the last 20 years. Cure, unfortunately, is not yet possible, also reflecting our limited understanding of the pathogenesis of these disorders. And immunomodulatory therapies, including biologicals, which are successfully used in IBD, are very disappointing in PBC and PSC. Perhaps it's the wrong concept. I don't think so. I think the problem is the late diagnosis. And of course, the role of the gut-liver axis, especially in PSC, and the question whether control of inflammatory bowel disease in PSC is going to have an impact on PSC, I think merits future studies. And we have interesting developments with microbiota and vancomycin. The really most promising therapeutic avenue are nuclear receptor ligands, such as FXR, PPAR, and glucocorticoid receptor ligands, which work as immunometabolic drugs. And I could show you that these compounds are now second-line treatments in PBC where ERS are non-responders. We have an add-on strategy with obeticholic acids and fibrates, or even combinations. With PSC, we have the interesting developments with NoEDC and Silofaxor with phase 3 studies, which hopefully will lead to licensed drugs in the near future. I think we have to be more proactive. These are complex diseases which require combination therapies. I think we have to risk stratify patients, aim at deep biochemical remission, complete normalization, and react early if this is not efficiently achieved. And I think, especially in PSC, we need an earlier diagnosis, perhaps MRCP in patients with IBD, irrespective of elevated liver tests, because once we have lost the bile ducts, it's very difficult to replenish them. Even if we can treat the fibrosis, the bile duct loss is very difficult to compensate. And I think this is an important therapeutic consideration. So with this, I thank you for your attention. I'm looking forward to the discussion, and I also will try to turn on my camera for the discussion. Thank you very much for your attention.
Thank you, Michael, for this fantastic exposition. Any question? Raúl Andrade.
Thank you very much, Michael. Fantastic presentation, fantastic updates on the topic. The PSC is a much more complex disease than PBC, and you know the endpoints for the new drugs, NOR-U-deoxycholic acid. Should they include, for example, the effect on biliary structure, for example, that are a common complication of the disorder? What do you think?
Yeah, this is a very good question, because in PSC also alkaline phosphatase is not really a reliable biomarker. And I think this is part of the problem, because the current studies are still oriented on the biochemical response. Of course, we also include histological response, which is mainly stabilization of fibrosis and bile duct loss. And also, in addition, of course, clinical endpoints such as the development of dominant strictures, cholangitis is included as secondary endpoints. But the main endpoint in both phase 3 trials at the moment is the impact on liver histology, stabilization or reversal of fibrosis, which of course is a very high bar.
Okay, thank you. Any other question, Maria Buti?
Thank you, Michael, for this excellent presentation. Having now second-line drugs for PBC, my question is, do you think with the first-line drugs we have to go to completely normal phosphatase alkaline levels and gamma GT, or we can be still having some degree of tolerance?
Yeah, thank you very much, Maria, for this excellent question. I think we have to be more proactive. I think we really should aim at total normalization. And at least ERSA tells us that not only normalization, but if you take bilirubin, even if I may use the term deep biochemical remission with the bilirubin below 0.6 is the aim. And I think this is currently evolving. I think we were too conservative. Of course, we are improving the survival in patients which meet the Barcelona or the Paris criteria. We also improve the survival in patients which do not fully meet these criteria. But I think the best is to reach complete normalization. And I think this should be the aim. And I think we should make this decision after 12, perhaps already after 6 months. I think data also point to that, because especially in young patients with aggressive ductopenia, they may have lost too many ducts if you wait too long. And I think we should be more proactive in combining therapies, even, you know, combining fibrates with obeticholic acid and ERSA as triple therapy to reach this complete normalization. And perhaps in the future, we'll have biologicals, which also can be added. So it should be a step up therapy like in IBD or in rheumatology in the future.
Okay, thank you. Any other question? No? No. Well, pues, thank you. Thank you very much, Michael.
Thank you very much, and sorry for the technical problems at the moment. Thank you.
Okay, okay. Thank you.